Hello everyone, let's learn today general features and attachments of the femur. Now we know femur is a longest bone of the body and approximate length in adult is 45 centimeter, that is approximately 1/4 of the total height of an individual. And you know it's a typical long bone, so it has got two ends, upper end and lower end, and intervening shaft. The shaft has got three borders and three surfaces. Now regarding side determination, you can watch my separate video. So this is right femur I have, and as I mentioned, it has got upper end and lower end. The upper end can be identified by a head, and lower end bears two condyles, medial and lateral. So let's start with upper end. The upper end has got a globular head, a constricted neck, and two trochanters, greater trochanter and lesser trochanter. Now let's see first the head. The head is forming more than half of a sphere, and it is smooth, it is articular, and in living it is covered by hyaline cartilage, except in the center. You can see over here there is a depression which is termed as fovea or fovea capitis, whereas rest of the portion is articular and it articulates with the acetabulum. Together they form hip joint. So this is acetabulum and it has got a corresponding smooth articular surface, and together they form ball and socket variety of synovial joint. The fovea provides attachment to round ligament of head of femur. It is also called as ligamentum teres femoris, which extends from acetabular notch, over here you can see, to the fovea capitis. So this round ligament will provide a passage for transmission of blood vessels. The blood vessels are coming from branches of medial circumflex femoral and obturator vessels, and a small circular area around the head is supplied by these vessels. Similar like ligamentum teres femoris, in our body we have got two other ligaments which are having similar name, namely ligamentum teres hepatis and ligamentum teres uteri. Now next to the head is a constricted neck, you can see over here, which bears two surfaces, anterior and posterior. It has got two borders, upper and lower. The neck is continuous below with the shaft. The anterior surface is flat and it bears multiple oblique grooves, you can see over here, and the anterior surface is continuous with the anterior surface of the shaft. The meeting point is represented by intertrochanteric line. Now the posterior surface, it is concavo-convex and bears a faint groove which lodges tendon of obturator externus. The obturator externus muscle takes origin from the outer aspect of obturator foramen over here, and then the tendon runs spirally along the inferior and posterior aspect of the neck. So over here there is a faint groove which lodges tendon of obturator externus, which finally gets inserted into trochanteric fossa over here. Beyond to that, the posterior surface is continuous as greater trochanter, which is a junction between neck and the shaft laterally, and posteriorly the neck and shaft, they are demarcated by intertrochanteric crest. The upper border is straight and concave, whereas lower border is oblique and flat. The approximate length of neck is 5 cm in adult, and which is directed upward, medially and slightly forward. So if you see it from in front, you can realize that it is directed upward and medially, whereas if you see it from above, right, these are the condyles. So if you put it in anatomical position, you can realize that the neck is not directed directly medially, but it is directed slightly forward. So there forms an angle which is termed as angle of anteversion, or it is also called as angle of femoral torsion. So in this diagram you can clearly make out that neck is slightly anteverted. So if you draw an imaginary line passing from center of head and neck, and if you draw another line which is passing from posterior aspect of both the condyles. This is superior view. So these two imaginary line will meet at 15 to 20 degree angle, which is termed as angle of femoral torsion or angle of anteversion. Similarly, when you draw an imaginary line passing from center of head and neck, and if you match it with long axis of the shaft, there forms an angle between neck and shaft, which is termed as neck shaft angle. So here again in this diagram you can see the imaginary axis passing from center of head and neck. When it meets with the long axis passing from the center of the shaft, there forms an angle which is approximately 126 degree in adult, which is the normal range or coxa norma. It is also termed as neck shaft angle or femoral neck angle, or it is also termed as CCD angle, which means caput column diaphyseal angle. So in adult it is around 126 degree, whereas in newborn the normal angle is around 150 degree. So here you can see the purpose of neck is to keep the shaft away from the pelvis, and that permits free swinging movements. So here you can make out that from acetabulum the weight will shift to head, then to neck, and then to the shaft. So to overcome the bending forces, inner aspect of the neck is having a strong bony buttress which is termed as calcar femorale. Now along the lateral aspect of neck and shaft junction there is a greater trochanter which is having three surfaces: lateral, medial and anterior, plus it has got two borders, superior and posterior border. The medial surface has got a depression, and this depression is within the trochanter, so as the name given to it is trochanteric fossa. You can see over here, you can clearly make out this is the trochanteric fossa, which receives insertion of obturator externus, and it is a site of formation of trochanteric anastomosis. Above and in front of trochanteric fossa, over here you can see the medial surface bears a flat impression which receives insertion of obturator internus with gemellus superior and inferior. The anterior surface is rough and it receives insertion of gluteus minimus muscle. Now the lateral surface, it has got an oblique ridge, you can see over here, which runs downward and forward, and this ridge receives insertion of tendon of gluteus medius. Now this ridge forms two triangles along the lateral surface, one is in front and one behind. The anterior triangle is related to a bursa that separates bone from tendon of gluteus medius, whereas posterior triangle is related to another bursa which separates this bone with tendon of gluteus maximus. The upper border along its posterior-superior part shows a bony elevation, you can see over here, which is slightly inturned, and this receives insertion of piriformis, whereas the posterior border below is continuous as intertrochanteric crest. Now the lesser trochanter is another bony elevation which is situated at posteromedial aspect of neck and shaft junction. It is conical, and both these trochanters are example of traction epiphysis. So obviously it is providing attachment to muscles. Now anterior aspect of lesser trochanter near its apex, this portion provides insertion to psoas major, whereas near the base there is insertion of iliacus muscle. Now the junction between anterior surface of neck and shaft, it is represented by intertrochanteric line, which provides attachment to two ligaments, namely joint capsule for the hip joint and iliofemoral ligament, and it provides attachment to two muscles, in upper part highest fibers of vastus lateralis and in lower part to the highest fibers of vastus medialis. Now in the posterior aspect, the neck shaft junction between two trochanters are represented by a sharp bony ridge which is termed as intertrochanteric crest. Obviously it is extending from greater trochanter to lesser trochanter. Along its midpoint you can see a tubercle which is termed as quadrate tubercle, which receives insertion of quadratus femoris. Now when we articulate head of femur with acetabulum, we can see that the apex of greater trochanter, the center of head and pubic tubercle, they lie in same horizontal plane. Now let's study the shaft. It is cylindrical, and if you see it from side, it will show ventral convexity. And specifically in middle third, it has got three borders and three surfaces. So the borders are medial, lateral and posterior, whereas the surfaces are anterior, medial and lateral. And out of the three borders, if you see the posterior border, specifically in middle third, this portion is termed as linea aspera, which is a strong bony buttress. And if you see the bone from side, this linea aspera will resist compressive forces and it prevents anterior bowing of the shaft. Now when we see closed lip, linea aspera, it shows a medial lip, a lateral lip and an intermediate area. So the middle third has got medial border, lateral border and posterior border in the form of linea aspera, and it has got anterior, medial and posterior surfaces. Now if you trace the medial lip of linea aspera above, it is continuous as a spiral line. You can see this, and this spiral line, obviously the name is suggestive of it is spirally oriented, and it encircles the upper third of the shaft, and above it is continuous as intertrochanteric line. And if you trace lateral lip of linea aspera above, it forms a rough margin, lateral margin of a rough area. This rough area is termed as gluteal tuberosity. And if you trace this lateral margin above, it will reach up to the greater trochanter. So both medial and lateral lip of linea aspera above, they diverge and they form a triangular posterior surface that shows a roughness in its lateral part, which is termed as gluteal tuberosity. Now similarly, when you trace medial and lateral lip of linea aspera below, they will again diverge and they form a triangular popliteal surface. So the medial lip of linea aspera is continuous as medial supracondylar line, and which ends at a bony elevation just above the medial condyle. This bony elevation is termed as adductor tubercle. Similarly, the lateral lip will continue as lateral supracondylar line, and that will reach up to lateral condyle. So below there is a formation of additional popliteal surface. So we can say that the shaft of the femur has got three borders, medial, lateral and posterior, plus five surfaces: medial surface, lateral surface, anterior surface, plus additional posterior surface in upper part and popliteal surface in lower part. Now in thigh, there are three compartments and they are separated by three intermuscular septa which will merge with the deep fascia. So in this diagram, this is to show you that the right femur with its cross section at middle third showing linea aspera with medial lip, intermediate area and lateral lip. So medial lip is providing attachment to medial intermuscular septum, intermediate area to the posterior intermuscular septum, and the lateral lip will provide attachment to lateral intermuscular septum, which is very thick and which will merge with iliotibial tract. So now you can see there is a formation of three compartments: anterior compartment between medial and lateral intermuscular septum, medial between medial and posterior, whereas posterior compartment is formed between posterior and lateral intermuscular septum. So in anterior compartment we'll find quadriceps femoris plus sartorius, in medial compartment adductor muscles, and in posterior compartment the hamstring group plus short head of biceps femoris. Here in anterior compartment the nerve is femoral, here there will be obturator nerve, and here in posterior compartment there will be sciatic nerve. Now the anterior surface and lateral surfaces in their upper 3/4 provide origin to vastus intermedius. Now next attachment is vastus medialis, which takes origin as a continuous line. So the origin starts from lower part of intertrochanteric line, and the origin continues with spiral line, medial lip of linea aspera in front of medial intermuscular septum, and beyond it is continuous to the medial supracondylar line in its upper two-thirds. So up to this point there is origin of vastus medialis. Let me show you in diagram. So in this diagram you can see right femur with its posterior aspect showing attachments. In the middle third you can see medial lip, lateral lip and intermediate area of linea aspera with medial, lateral and posterior intermuscular septa. Now we were discussing attachment of vastus medialis. So as we have discussed, it is having a linear origin which starts from lower part of the intertrochanteric line and which is continuous as spiral line. So over here you can see there will be a linear origin of vastus medialis which will continue over medial lip of linea aspera in front of this medial intermuscular septum. So this dotted line is suggestive of attachment of medial intermuscular septum. So the origin is in front and beyond it is attached to the medial supracondylar line into its upper two-thirds. So this is the linear origin of vastus medialis. Now next is attachment of vastus lateralis, which starts from upper part of intertrochanteric line, and then the linear attachment is continuous with anterior and inferior aspect of greater trochanter, and which is continuous as a lateral sharp margin of gluteal tuberosity. Over here you can see, and beyond the attachment is continuous to the lateral lip of linea aspera up to its upper half. So up to this point there will be origin of vastus lateralis. So here in this diagram you can see this rough area is gluteal tuberosity, and along its lateral margin there will be attachment of vastus lateralis up to upper half of lateral lip of linea aspera. This dotted line is suggestive of attachment of lateral intermuscular septum. So it is attached lateral to the lateral intermuscular septum over lateral lip of linea aspera. Above the attachment extends up to inferior and anterior aspect of greater trochanter and to upper part of intertrochanteric line. Now other muscles are mainly taking origin from linea aspera. Let us see the attachments. Next to the vastus medialis over linea aspera there is attachment of medial intermuscular septum, and beyond that there will be attachment of this posterior intermuscular septum showing the dotted line. So as we have discussed, between medial and posterior intermuscular septum there will be adductor compartment. So obviously there will be attachment of adductor muscles. Now let's see first attachment of pectineus. You can see over here it is attached in linear pattern beyond root of lesser trochanter to the linea aspera. Next to it, deep to the pectineus, there will be attachment of adductor brevis again in linear pattern. So it is extended up to upper part of the linea aspera. You can see over here deep to the pectineus, and beyond you can see deep to the medial intermuscular septum in lower part of linea aspera, lower half of linea aspera, there is attachment of adductor longus. So adductor brevis and adductor longus are remaining in line to line with each other. So in upper half there will be attachment of adductor brevis, and in lower half of the linea aspera there will be attachment of adductor longus. Next to the attachment of adductor brevis and longus, deep to that there will be a continuous linear attachment of adductor magnus. You can see over here. So the attachment commences above just medial to the gluteal tuberosity. You can see over here, and then it is attached throughout the extent of medial lip of linea aspera, deep to adductor brevis and longus, and then to medial supracondylar line throughout it extend up to adductor tubercle. Now along its course over medial supracondylar line, the attachment shows a gap which is called as hiatus magnus, or this is the fifth osteoaponeurotic opening which allows passage of femoral vessels from subsartorial canal to popliteal fossa. So beyond this opening, the femoral vessels are termed as popliteal vessels. Next comes attachment of posterior intermuscular septum. So between medial and posterior intermuscular septum, we'll see attachment of adductor compartment muscles. Now we know between posterior and lateral intermuscular septum, there is posterior compartment containing hamstring group of muscles and short head of biceps femoris. Now hamstrings are not attached anywhere along the femur, so in the posterior compartment we'll get attachment of only short head of biceps femoris, which is not included in hamstring group. So again it takes origin as a linear pattern between posterior and lateral intermuscular septum, and attachment is continuous below to the lateral supracondylar line into its upper two-third. So there is a continuous attachment throughout the length of linea aspera and to upper two-third of lateral supracondylar line. Next is attachment of lateral intermuscular septum, which limits the boundary of posterior compartment, and beyond that there is anterior compartment. So beyond lateral intermuscular septum, we'll see attachment of vastus lateralis that we already discussed. Next to vastus lateralis, the lateral surface along with the anterior surface in its upper 3/4 will provide origin to vastus intermedius that we have discussed. Now let's see structures attached over linea aspera from medial to lateral. The medial most comes is vastus medialis, then comes medial intermuscular septum. Beyond that there is attachment of adductor brevis and adductor longus in same line. Then comes attachment of adductor magnus. Then comes posterior intermuscular septum, which limits the boundary of medial compartment. Then comes attachment of only short head of biceps femoris. Then comes lateral intermuscular septum, and there will be attachment of vastus lateralis. Now, like linea aspera, let's just enumerate the muscles attached to the posterior surface in upper third of the shaft. From medial to lateral, the attachments are vastus medialis, then comes attachment of pectineus, adductor brevis, adductor magnus, and beyond that there is gluteal tuberosity, which receives insertion of 1/4 fibers of gluteus maximus, and then there is lateral sharp margin of gluteal tuberosity, which is providing attachment to vastus lateralis. Now the popliteal surface above condyles and between medial and lateral supracondylar ridge. This is forming floor of upper third of popliteal fossa, and it is related to popliteal vessels. Now along its antero-inferior aspect over here, this region just above the medial condyle, this portion provides attachment to medial head of gastrocnemius, whereas lower one-third of linea aspera over here, this portion provides attachment to plantaris muscle. So medial supracondylar line throughout its extent provides attachment to medial intermuscular septum and adductor magnus, whereas in upper two-third it provides attachment to vastus medialis. And similarly, lateral supracondylar line throughout its extent provides attachment to lateral intermuscular septum, whereas in upper two-third it provides attachment to short head of biceps femoris, and its lower one-third it provides attachment to plantaris muscle. Now let's see lower end. As you know, it bears two condyles, medial and lateral condyle. The medial condyle is bulkier and it is more deviated, whereas the lateral condyle, which is shorter, stouter, and it is more in line with the shaft of femur. So this is medial condyle, this is lateral condyle. Now between the condyles, lower end shows a depression which is termed as intercondylar notch or intercondylar fossa. Now anterior, inferior and posterior aspect of both the condyles are articular, and you can see over here there is a V-shaped articular surface. So this is patella and this is its posterior articular surface, and over here in this region it articulates with the patellar articular surface of femur like this, and together they form part of knee joint. The femoropatellar articulation is saddle variety. Now you can see over here over lateral condyle the articular surface is going beyond the articular surface of medial condyle. It is more extensive. So this portion of the patellar articular surface will come in contact with the wider lateral articular surface of patella like this. Now rest of the articular surface, which is known as tibial surface, along the inferior and posterior surface. Now this will come in contact with the corresponding condyles of tibia, which is separated by menisci. So like this, the tibial articulation will take place along the inferior surface and posterior surfaces of both the condyles of femur. Now medial condyle along its medial surface shows a bony elevation, and this is termed as medial epicondyle, which provides attachment to tibial collateral ligament. Now in upper part of the medial condyle there is another bony elevation which is termed as adductor tubercle. When you trace medial supracondylar line, you will end up at adductor tubercle. Now this adductor tubercle has got dual importance. Number one, it provides attachment to ischial or hamstring head of adductor magnus, and the epiphyseal line of the lower end of femur will pass through the adductor tubercle. Similar like medial condyle, on lateral aspect of lateral condyle, there is a bony elevation which is termed as lateral epicondyle. Now this lateral epicondyle provides attachment to fibular collateral ligament. Now postero-inferior to the lateral epicondyle there is a groove. Anterior part of this groove will provide attachment to popliteus, whereas posterior part of the groove will lodge tendon of popliteus during flexion of knee like this. Okay. Now postero-superior part of lateral epicondyle there is another depression, and this is providing attachment to lateral head of gastrocnemius. Now next is intercondylar notch or intercondylar area, which is having a medial wall, a lateral wall and a floor. So this is medial wall, which is basically the lateral aspect of medial condyle, and along its antero-inferior aspect over here it provides attachment to posterior cruciate ligament, whereas the lateral wall, which is actually the medial aspect of lateral condyle, this lateral wall along its postero-superior aspect, you can see over here there is a depression, and this provides attachment to anterior cruciate ligament. So both the walls of intercondylar notch provide attachment to cruciate ligaments. So along the medial wall at its antero-inferior aspect there is posterior cruciate ligament, and along the lateral wall to its postero-superior aspect there is attachment of anterior cruciate ligament. Now when you see both the condyles from below, along its lateral wall, intercondylar notch shows a subsidiary notch, you can see over here, that lodges anterior cruciate ligament during erect posture or during extended knee. Now this is a characteristic feature of mankind due to the adoption of upright posture. Now posteriormost part of floor of intercondylar notch is termed as intercondylar line, which provides attachment to capsular ligament of knee joint and oblique popliteal ligament. Now capsule of knee joint is attached posteriorly along the intercondylar line, and medially it includes posterior articular surface of medial condyle, and when it reaches to medial surface of medial condyle it shows a linear attachment 1 cm above and parallel to inferior articular surface like this. Similarly, on lateral condyle it includes the posterior articular surface of lateral condyle, and when it reaches to the lateral surface of lateral condyle it again shows a linear attachment 1 cm above and parallel to the inferior articular surface like this. And here the attachment takes place in such a way that it includes origin of tendon of popliteus over here, but it excludes attachment of lateral head of gastrocnemius. So over here there is attachment. Now on the anterior aspect the capsule is deficient above the patellar articular surface, and that forms a gap through which a synovial pouch comes out from knee joint. That pouch is termed as suprapatellar bursa. Now the summit of this pouch receives insertion of articularis genu. Now articularis genu is a small muscle which is attached to the anterior surface of shaft of femur, below the origin of vastus intermedius. The capsular ligament of hip joint is attached to upper end of the femur in a continuous line along the intertrochanteric line, upper margin and root of the greater trochanter over here, lower margin of the neck, a little in front and above the lesser trochanter over here, and posteriorly it is attached approximately 1 centimeter medial to the posterior surface of neck like this. Okay, so anterior surface of the neck is intracapsular, whereas medial part of posterior surface of the neck is intracapsular. Now when we hold femur in anatomical position, lower surfaces of both femoral condyles will assume a horizontal position. So the long axis of shaft of the femur will be obliquely running. Now if we put femur like this on a flat surface, assuming that the lower ends of both the femoral condyles are in a horizontal plane, so you can see the obliquity of the shaft of the femur, and if we try to join tibia from below, you can clearly make out that the long axis of shaft of femur is making an angle with long axis of shaft of tibia, and normally in adult the angle is 170 degree, which opens laterally. So this is regarding general features and attachments on the femur. Hope you understood well. Thanks for watching.